Good morning, ladies and gentlemen. Welcome to the 2021 HIV Community Engagement Forum. My name is Chowie. I'm a HIV physician in the National Center for Infectious Diseases, and I will be your MC for today. Before we begin, I'd like to invite you to view the video that's created by SNAF and the National HIV Programme, designed to educate the public on HIV testing, treatment, and discrimination. I hope you have enjoyed the video. Please note that CP points will be awarded at the end of the event via the QR code provided, and also note that today's event will be recorded and uploaded onto YouTube. The topic of today's forum is increasing HIV testing in Singapore, and some of you may wonder why this topic is chosen. Since the advent of antiretroviral therapy, or ART, the mortality attributable to HIV infection has been reduced by 80%. But despite this, 680,000 people still died of AIDS-related illnesses worldwide in 2020. The Joint United Nations Programme on HIV/AIDS aims to end the epidemic by achieving the 90-90-90 targets. That is to say, 90% of all people living with HIV will know their diagnosis, 90% of all people diagnosed with HIV will receive ART, and 90% of all people who receive ART will achieve durable viral suppression. As of 2020, 80% of people in Singapore who have HIV infection are aware of their serostatus, 91% of those who are aware are receiving treatment, and 91% of those who are on treatment have achieved durable viral suppression. While these findings are promising, more can be done to increase HIV testing rates, which brings us to today's forum. Now that we understand the agenda for today's meeting, it gives me great pleasure to introduce my dear friend and colleague, Associate Prof. Wong Chen Siong, Deputy Director of the National HIV Programme, to deliver his opening remarks and present on the importance of HIV testing. Chen Siong, please.
Thank you so much, Xiaoyi, for that kind introduction. And I just want to thank everyone for taking time off to spend your Saturday morning with us. So on behalf of the National HIV Programme, as well as all the friends and colleagues who are joining us as panelists today, I extend a very warm welcome to you and hope that you have a fruitful morning. As Xiaoyi was, sort of painted the foundations for this morning's talk. As at the National HIV Programme, we really feel that HIV testing, talking more about HIV testing is of critical importance, and that's why I've titled my my talk today, HIV testing, the critical first step. And it's really, and the image that I put as my opening slide really has some meaning as well, because without testing, without that first step of knowing one's HIV status, we really do not have any way of moving forward. And I will show you today in my talk that HIV testing and getting more people tested is really the way forward into ending HIV in our lifetimes. The first question I think we need to ask ourselves, and what I'll be hoping to answer for you today, is why is it important to make sure that we have HIV testing and screening scaled up in a really big way in Singapore. So I think most of us are familiar with this first diagram, this cascade. The HIV testing is really the first step in allowing us to enact the rest of the HIV care continuum or care cascade. And by cascade, we really mean the journey that people take in getting from a HIV diagnosis to being undetectable, to having a completely suppressed viral load, and therefore enjoying good health for themselves and stopping the chain of transmission to others. This cascade starts off with HIV screening and diagnosis. The second step is being linked to care. The third is being engaged in care and retained in HIV care. The next step is initiation of highly active, potent antiretroviral medications. And then the last and fifth step, or rather the fifth step, is that of virologic suppression. Only when we have HIV testing and making sure that people are aware of their own HIV serostatus or HIV diagnosis can we start on this journey, can we start on this staircase, as it were, of multiple steps of getting people to a point where they are virally suppressed. Without knowing one's serostatus, one simply cannot start on this cascade of care. Now, this the importance of HIV testing is further underlined by the UNAIDS 90-90-90 targets. Now, I'm sure most of you in this room and in this forum today may have heard of the 90-90-90 targets before, but just for those who need a bit of a refresher, these were ambitious targets that were set in the middle of the last decade, and really where the United Nations HIV and AIDS program said that in order for us to get to a point where we can realistically end HIV as a public health concern globally, we really need to achieve three goals, right? We need to make sure that 90% of all people who are infected with HIV are aware of their diagnosis. Of these 90%, we then need to make sure that a further 90% are started on highly active combination antiretroviral therapy. And of these people who are started on antiretroviral therapy, at least 90% need to have an undetectable viral load or be virally suppressed. If we hit each of these targets, then the number of new diagnoses per year will be reduced, and hopefully to a point where where HIV/AIDS will no longer be sort of the pressing, critical public health issue that it remains to this day, since it was first discovered in the early 1980s. So why is it important that we achieve these 1990 targets? And bear in mind that the first of these 1990 targets is that of HIV diagnosis, right? And the only way we can get diagnosis by getting a test done. Why is it important that we try to achieve these targets? Why is it important that we get people diagnosed so that we can go on to then achieve the further 290s? Now, these are just some graphs from the UNAIDS report, and this is actually from the GAP report that was published in 2014. So data is probably a little bit, we will see this continuing. The blue line, the bottom line, shows that if we reach 90-90-90 globally by 2020, what will happen? The green and red lines are what will happen if things continue at the current state without us aiming to achieve 90-90-90. You can see that in terms of new HIV infections, if we don't do anything, if we just continue as things are, right, the number of new infections are going to climb, are going to continue going up over time. In 2030, we might hit 2.5 million new cases of HIV infection every year. However, if we were able to achieve the 90-90-90 targets by 2020, so this is sort of already in the past, but more realistically by 2030, you can see that the new diagnosis of HIV will decline to less than 500,000. In fact, less than 300,000 cases per year. So it's of an order of magnitude difference, right? It really makes a difference if, based on these models, based on these expectations, what we could achieve if we got more people tested, more people treated, and more people with an undetectable viral load. Now, similarly, if we look at the outcome, right, not just new diagnoses, but also people who are dying of HIV/AIDS, if we try our very best to get more people diagnosed, more people screened and tested, and therefore started on treatment and getting an undetectable viral load, we could also see a significant decrease in AIDS-related deaths. However, if we don't do anything and we just, disregard the 90-90-90 targets, then the number of AIDS-related deaths will continue to go up. And I think this kind of makes sense because if people aren't treated, if people aren't, given a chance to achieve an undetectable viral load, then their own health suffers, and the risk of getting severe illnesses due to HIV and dying because of HIV are accordingly higher. So achieving the 90-90-90 targets really does have a real-world impact on how HIV/AIDS will progress globally as well as locally. Now, this is a bit of a busy slide, but I just want to draw your attention. So this is really global progress, right, on the 90-90-90 cascade. And these are slides that were shared at the Singapore AIDS conference last year, as well as the Singapore HIV Congress the year before. So this is really looking at, over years from 2015 to 2019. We can actually see that if we look at the first one, the number of people with HIV diagnosed, in 2015, of the 90% target that we wanted to reach, it was only about 70% globally, right, across the world. Thankfully, over the next 5 years in 2019, that has gone up by about 11% to 81%, but it's still far short of that 90% target that we want to reach. And when we consider that every year, about 1.5 to 1.8 million people are diagnosed with HIV, a 10% of that remains undiagnosed, and I'll show you in a short while why that gap of people who are not yet diagnosed is truly quite important. Now, having said that, where are we doing in Singapore on the 90-90-90 targets? And once again, I thank for these slides and give credit for these slides to Professor Vernon Lee from the Ministry of Health. So if we look at 2018, which is the most recent year for which we have this data, and this was presented at the Singapore AIDS conference last year, of that first target, we are at about 80%, right? So we are not too far off from the global average. So we want to have as many people who are truly infected with HIV in Singapore diagnosed and aware of their condition as possible. We're at about 80%. So we have a ways to go. But thankfully, if we look at our progress through the years, we have also steadily increased over time. And this is from 2014 to 2018, over 5 years. There's also been an increase from about 2/3 or 66% all the way up to 80%. And we really want to capitalize on these gains and continue improve. So, there are other ways of answering the question of why it's important, right? So we know that by diagnosing people, by having people aware of their diagnosis, they are able to start on this cascade and start to seek care, get treatment, get medication, start living healthy lives, and stopping the chain of transmission. Another way of looking at it is also that how many people are present with a late diagnosis. That means they eventually get diagnosed with HIV, they eventually get tested and made aware of that diagnosis, but perhaps at a later stage than we would like. And what is this later stage? Because ideally, we want to diagnose people with HIV when they're healthy, when they are not exhibiting or they don't have any signs and symptoms of a weakened immune system due to, perhaps having had uncontrolled HIV infection for a period of time. I think Dr. Choi, my colleague, will talk a little bit about the, what HIV/AIDS does. But I think most of us are aware that HIV infection, this viral infection, really targets our immune system and makes us more susceptible or more vulnerable to infections by other bacteria, other viruses, or even certain types of cancers. But this takes time to develop, right? And what we really want to do is catch people or diagnose people at a point when their immune systems are still healthy because they haven't been infected with HIV for too long a period, and start them on treatment at that point. Now, in 2020, so data that was released by the Ministry of Health in June this year showed that there were 261 new cases of HIV infection in the year 2020. So this is a significant reduction from previous years, and we are glad for this. Unfortunately, of these 261 cases, more than half, so 53% of people, presented in a late stage of infection. And what we mean by this is that they either presented with an AIDS-defining illness already at the time of diagnosis, something once again that Xiaoyi will talk about later on, or they presented with a significantly weakened immune system, as indicated by having a CD4 helper cell count of less than 200, which is, by most definitions, the level below which we consider people to be quite weakened in terms of their immune system. Now, this is not unique to Singapore. We can see that the problem of late diagnosis or late presentation with HIV is actually fairly common in both our region as well as internationally and in other countries as well. So this is something that we really want to shift the needle for. Now we've talked, so in my previous slide, I talked about people presenting with late stage infection and hence with a AIDS-defining illnesses, which impacts their own health. Now it can also have a public health impact, which means impacting the health of others, right? And we can see that HIV testing, because we are able to diagnose people, make people aware of their diagnosis, start them on treatment, also allows us an opportunity to stop the chain of transmission, preventing people or reducing the risk of people to unknowingly transmitting the virus onto their partners or to their loved ones. There have been studies, some modeling studies once again, to show that if we this was data from the United States, which showed that even in a situation where 83.5% of people were aware of their HIV diagnosis, not too bad, still a little bit short of that 90%, but doing not too bad. And with 14.5% of people who are unaware of their diagnosis, this small proportion of people who did not know their HIV status were represented a disproportionate number of new infections. So what this really means is, it kind of makes sense if you think about it. If you're not aware of your own HIV diagnosis, or perhaps if you're not even aware of the fact that you are at risk of HIV infection, and hence you don't think of yourself as being at risk of being infected, you might not take the necessary precautions that are necessary to prevent your partners from being infected, such as the correct and consistent use of condoms during sexual intercourse, for example, and hence this increases the risk of you unknowingly and unwittingly transmitting the virus onto others. So closing this gap may help to close this gap. In other words, reducing the number of people who are not aware of their HIV status is likely to have a really significant impact on new diagnoses of HIV going forward. Not only because When you're aware of your status, you're able to get people on treatment with an undetectable viral load. And we now know that undetectable equals to untransmittable, but also because you're more likely to take the necessary precautions to prevent onward transmission onto your partners. So there are international guidelines, and this is something once again that Xiao Yu will be talking about for how to screen and test people. But suffice to say, anyone who's ever been sexually active and who do not have other behavioral risk factors should all be offered at least one test in their adult lives. And individuals or people who belong to groups where there are behaviors or certain aspects which put them at increased risk of HIV transmission should have a higher frequency of HIV testing that should be offered either in the community or healthcare institutions. And these include the individuals or people belonging to groups that I've indicated here, including men who have sex with men, people who use injection drugs, people who are partners of HIV infected individuals who may not have a suppressed viral load yet, and of course all pregnant women. So I want to sort of circle back to how we are doing in terms of our HIV screening now that we have talked about what the guidelines talk about. Just more broadly in Asia, we can see that the percentage of people who are aware of their status is still below 80%, although it has been increasing over time. Similarly, because less than 90%, so only about 74% of people across the Asia Pacific, and this was in 2016, if I'm not mistaken. 2018, were aware of their diagnosis. Hence, only about 45% in total of people with HIV infection had an undetectable viral load. So once again, increasing this will hopefully increase the proportion of people on treatment, will then go on to increase the proportion of people who have an undetectable viral load, at least in the Asia Pacific. I've kind of sort of talked about this before already, that even in 2014, 49% of people in Singapore presented at the late stage of infection. As I've shared in an earlier slide, when we came to 2020, that proportion has actually increased, although the raw number, the absolute number of people who were diagnosed with HIV, newly diagnosed with HIV in 2020 had come down, but still, the number of people who get tested as a result of voluntary testing is still rather low. Now, I just want to spend the last few minutes, I think I've already sort of belabored the point or stressed the point over and over again about why getting people tested is so important for personal health, for public health reasons, for the health and safety of not only the individual, but also the people around them, their sexual partners especially. I just want to talk a little bit now about the fact that there are barriers to testing in our region, just broadly speaking. And I think we can't run away from talking about HIV testing without talking about the individuals who are particularly at risk for HIV infection in Singapore as well as in the Asia Pacific region. In Asia, 95%, almost everyone amongst young people aged 45 and below who are newly diagnosed with HIV, they fall into at least one of these sort of most affected key populations, right? Either men who have sex with men, people who use drugs, transgender individuals, people who exchange sex for money or other commodities, so sex workers, as well as prisoners. And if you realize that most of these status, so being a member of many of these communities, is actually criminalized in this region, let's just say. There are other barriers as well. So of course, if we go back to this slide, if belonging to one of these groups or identifying as a member of one of these groups puts you in a state where you might potentially be criminalized and punished for your state of being, then of course, accessing HIV care, accessing HIV treatment might be quite challenging for people in these groups if enough measures are not taken to make them feel safe, for example. There are other barriers to HIV testing. There have been studies to show that there is a relatively high lack of HIV knowledge or a mismatch between risk behavior as well as awareness of their own risk. Of course, in the Asia Pacific, not all countries have convenient community-based clinics or key population-led clinics. Many people have to go to a specialist center to get HIV testing or treatment, which can make things rather inconvenient, especially for people who need to work. Fear of attendance at clinics and healthcare institutions, the fear and stigma that's associated with getting an HIV diagnosis, right? Many people may feel that, if I find out my diagnosis, I'm going to be stigmatized or discriminated against. Why find out my diagnosis? I'd rather not know. As well as anticipated and experienced stigma and discrimination of all sorts, unfortunately, also at healthcare institutions and clinics. So all of these are barriers that we need to address before we can get testing really scaled up in a bit more. And this last slide, I think, really just summarizes the last 2 points that I just talked about. So what have we really talked about today? I've told you about why HIV testing is important. It's the first step in starting on the HIV care cascade. I've talked about the fact that HIV testing is important not only for the individual's health, but also for the health and safety of the people around them, especially their sexual partners and their loved ones. And I've talked a little bit about the barriers that people living with HIV or who are at risk of HIV face, and which may then go on to reduce their likelihood of accessing HIV testing early and at a point where treatment could be started at an early point before they sort of fall sick. And I would now, like to hand the mic over to my next speaker. Of course, if you've got any questions, please do put them into the chat box. If you think of anything later on that you want to ask me, I'm always happy to answer emails. And I put this slide here to remind myself that I need to introduce my next speaker. And my next speaker is my very good friend and fellow HIV physician at the National Center for Infectious Diseases and the co-director of the Clinical HIV Program at NCID, Dr. Choi Chiao-Yi, who will be talking to you about populations at risk and who should be tested for HIV. Chiao-Yi, please.
Thank you, Chen Xiong. Okay, just let me share my screen. Okay, so thank you so much to Chen Xiong. That was a really very thorough presentation. My presentation will be a lot shorter because Chen Xiong has really covered the main gist on the problems that we face with HIV testing. And the main thing that I will be covering are who should be tested. So now that we all know the importance of HIV testing and why we are repeatedly emphasizing on this topic, the question now then is, where is HIV testing usually done in Singapore? So there's a few venues where these HIV testing occur. One of them, Chen Xiong has mentioned, is the voluntary opt-out screening program in the hospitals. This is a program that started by the Ministry of Health in 2008 in all restructured public hospitals for all adults inpatient in an attempt to try to increase HIV testing rate and reduce the late presentation of HIV. When we look outside in the community, there is 10 general practitioner clinics that currently provides anonymous HIV testing. Anonymous HIV testing is also provided by community-based organizations such as Action for AIDS, and perhaps in the future, we will also have self-testing. So first question is, who should we consider for screening? The population is quite large, and who are the ones who should actually fall under this consideration? And the answer actually is very broad. Actually, all individuals above the age of 21 years old and above should be offered HIV screening at least once in their lifetime. In Singapore's context, females above the age of 65 years old is the only one who is actually excluded from this population. And how we come about to this particular number is actually based on the CDC guidelines, which advise that all individuals should be offered HIV testing at least once in their lifetime, unless the seroprevalence of HIV in your country or population is less than 0.1. And for us, the only group that actually meets this criteria of a seroprevalence less than 0.1 are the females above the age of 65 years old. So outside of that, any individual for whom you have reasons to suspect will benefit from HIV testing should be offered one. So then how do we decide, who should be screened? I roughly divided the group that should be screened into 3 different groups. We can divide them into the medical, kind of like medical symptoms and condition, the special populations, and then the individual who have a high-risk behavior for HIV transmission. So for special population, that will be all pregnant women who should be offered HIV screening at each first antenatal visit. But I'd like to draw your attention back to the medical condition or symptoms part. So going through the different medical condition, the first one you see there is all individuals with tuberculosis. HIV increases the risk of tuberculosis by 20-fold compared to those without HIV. And also in Singapore, the estimated rate of HIV and TB co-infection is about 4.9%. So because of this, the rates are not low. Therefore, all individuals who have TB are screened for HIV in Singapore. The second, of course, is sexually transmitted diseases, and this includes conditions such as syphilis, chlamydia, as well as gonorrhea. And also not forgetting actually viral hepatitis as well, if you have reason to suspect that these are transmitted sexually. So why that's so? So we have certain conditions such as hepatitis A, which can be transmitted via oral anal sex. We also have hepatitis B and C, which can be transmitted sexually or even via needle use. So because they can be transmitted sexually, therefore it puts them still at risk of HIV acquisition, and they should be offered the screening. The last two is related to HIV-related symptoms. So one of them, of course, it's AIDS-defining illness, which I will go through. I'll show you a slide of what these AIDS-defining illness are, and it's the one that everyone is very familiar with. But the last one, which is the one that I'd like to draw your attention to, are symptoms that are suggestive of HIV infection, including acute HIV infection. So AIDS-defining illness is the late stage of HIV infection, whereas acute HIV infection is the early stage. And people often, I think this is the part where people often miss or forget that there are certain symptoms that we can pick up and offer screening for, and this should be recognized. So these are the AIDS-defining illness. I think everyone is familiar. There's a lot of them, obviously. The most common one that everyone knows is like oral thrush. That's the one that we know. And this can actually be found, online in the WHO guideline as well. So it's the one that everyone's very familiar with. But acute HIV infection is the one that I really want to talk about because it is the one that is actually quite neglected. So this is a study that is done in Singapore involving 34 men who have sex with men with acute HIV infection. If I draw your attention to the symptoms, you can see that the top three most common symptoms are fever, rash, and diarrhea. And I know what you're thinking. You're thinking this does not help you whatsoever. It is really quite generalized, and you are quite right. You look at the rest of the symptoms, it's things like headache, myalgia, and arthralgia. And then if you look at signs, the top three are lymphadenopathy, rash, and tonsillitis. I would only say at least lymphadenopathy doesn't really present often in dengue, but rash and tonsillitis can be quite kind of general kind of symptoms. And I know what everyone's thinking, at least at this point in time, at least for the physicians who are there, is that this really just looks like dengue, to be honest. And it's true, it does look like dengue, and we have done a study before. So we have done a prospective cross-sectional study between 2012 to 2015 between the National University Hospital, Tan Tock Seng Hospital, and the Alexandra Hospital to identify the seroprevalence of HIV, acute HIV infection among patients with dengue-like illness in Singapore. So febrile patients with 2 or more symptoms of dengue fever but have not been tested for dengue were identified and then offered screening for acute HIV infection. 140 participants were recruited, of which 3 were identified to have acute HIV infection. So this brings the seroprevalence to 2.1%. This is a little bit high, granted. There are similar studies that's done overseas, such as in US, which they do among people with infectious mononucleosis-like syndrome, because that's also another disease that have fever and rash, which is quite similar symptomology. And they found that the seroprevalence there is about 1%. It has also been done in Uganda, and seroprevalence has also been found to be about 1%. And this could be because the population that is done with this study is a little bit small, but that being said, it just highlights the importance that in individuals who have fever and rash and with diarrhea and whom you think that it's dengue fever, but if you screen and the dengue screen is negative, a lot of the time, a lot of physicians will say, oh, this is just a viral syndrome. It's fine. You viral fever. You can just go back and you will get better. But I think it just highlights the importance of thinking about HIV seroconversion as a potential possibility diagnosis. In this individual whom your dengue screen comes back negative, I would encourage everyone to take a sexual history and take a history for risk-taking behavior and offer HIV screen if relevant. And that's because once we miss this stage of acute HIV seroconversion, more likely than not is that they will eventually get better, as everyone always say for viral fever, and they probably will not present again until perhaps when they present there with AIDS-defining illness, which is then many years later. They will miss the best opportunity to treat them as early as possible. So once again, I just want to emphasize about the acute HIV seroconversion symptoms and illness, and to be able to recognize it and test for it. So now that we have talked about the initial screening of who should be screened, of which I have mentioned almost everybody 21 years old and above with the appropriate risk factors should be screened, except for females above the age of 65. The next question then is who should actually get repeat screening. So individuals who fall into this population should be screened at least annually. And they should have more frequent retesting 3 to 6 monthly based on their individual risk factors. So individual risk factors includes things such as having a new partner of unknown status, or having continuous high risk exposure, in which case then they should do about 3 to 6 monthly kind of screening. So once again, population-wise of who should be screened. So I divided once again into medical groups, drugs related, as well as behavior related. So in terms of medical, once again, quite similar to initial screening. So obviously individuals who have symptoms of acute HIV infection should be screened, and individuals who have sexually transmitted diseases should be screened as well. In terms of drug-wise, then any individual who have history of intravenous drug use should be advised to go for screening, because HIV can be transmitted by contaminated needles. Any individual who engage in sexual activities under the influence of alcohol or drugs, or have partners who have who participate in such activities, should be offered screening as well. And finally, as part of our recommendations, individuals who are on pre-exposure prophylaxis should be screened every 3 to 6 monthly. In terms of behavior, sexual partners of HIV-infected persons whose viral load is above the limit of detection, especially if the HIV RNA is more than 200 copies, should be screened. And the reason for this is that it's actually based on several studies that form part of the U=U campaign that have proven that if the in-sero-discordant couple, which is say that one individual has HIV and the other individual does not, but if the individual with HIV has a viral load that has been suppressed to less than 200 copies consistently for at least more than 3 months, they effectively do not transmit HIV at all to their partners. So this is how this number of HIV RNA copies come up. And also for persons who actually exchange sex for money, or partners of such persons with multiple sexual partners should go for repeated screening. Now, now that we have talked a lot about who should be initially screened and who should have repeated screening, the next question is then, when should HIV screening not be required? So unless required by prevailing legislation, such as HIV screening for work permit application, employment-related screening for occupations that do not involve exposure procedures should not require routine screening. And exposure-prone procedures refer to invasive procedure where there's a risk that the injury to the worker may result in the exposure of the patient's open tissue to the blood of the worker. And these procedures includes like place where the worker's gloved hand may be in contact with sharp instruments, needle tips, or with sharp tissue such as bones. So and it's procedures where the worker's hands are actually in a confined anatomical space where it may not be completely visible all the time. In other words, mainly medical related procedures. So anything outside of that, it's a bit hard to find reasons why they should be screened and they should not be screened. So I have gone through the initial screening, repeated screening, and who should not be screened. I thought it would be fun if we do a little bit of quiz, because those were the general group that actually can be screened. But there are certain medical conditions which are associated with HIV. It's not exactly acute seroconversion or AIDS-defining illness, but it's useful, I think, for physicians to be able to recognize them as kind of like indicators for potential HIV infection. So we will try, first I will have the questions, and then we will try to launch the poll. Hopefully it works. If if it doesn't work, then it's okay. Everybody just like kind of like think through the answer yourself, and I will just go through the answers anyway. For the non-medical part of the group, do not feel embarrassed. Just join in for the fun of it. So this is really mainly just educational. So the first question is, which of the following dermatological conditions can be associated with HIV infection? Is it A, B, C, D, combination of this, or all of the above? I think you will see the poll in front of you now. You can shift the tab away from to the side if it's blocking you. Is the poll done? Okay. Okay. So majority have selected all four, which is actually correct. And I'll just go through very quickly why this is the case. So before I go through A, C, and D, I just want to mention that B is the classic palmar-plantar rash of syphilis. I think it's quite classic. Usually it looks like a squamous macular rash that's seen. And usually most physicians who are familiar and they recognize this, they will screen for syphilis as well as HIV. So A, let me just move. A is actually seborrheic dermatitis. It is estimated to be around 35% of patients with early HIV infection and up to 85% of individuals with AIDS. So if you see this, you can once again take the opportunity, just take the history, sexual history, assess for the risk, and offer HIV screening if appropriate. This is psoriasis. We also know that psoriasis is associated with HIV infection. It can be what we call the presenting sign of HIV infection, although the one way to defining feature of psoriasis with HIV infection is that it's often very severe compared to other forms of psoriasis. They can have plantar, palmar, nail disease, arthritis, and widespread erythrodermic disease as well. This is herpes zoster, also known as shingles, sometimes in the community is known as SIR. So people living with HIV are at high risk of developing herpes zoster infection. And even though the incidence is actually declining with ART therapy. But I think in particular, while it's true that individuals above the age of 50 or the more elderly individuals tend to have herpes zoster, it is just something to note that it does happen quite easily among the individual who actually have HIV infection. In particular, I think if you see young individual who presents with herpes zoster, young men or young women, which is fairly unusual if their immune system if they are supposed to be immunocompetent and they present with herpes zoster, I will encourage you to please, once again, take a sexual history, assess the risk, and then offer HIV screening as well. This is the second question, which is, which of the following dermatological condition is an AIDS-defining illness? Is it A or is it B? So so I think most of you answered A and B. I think the answer is actually A, and I will explain quickly a little bit just to let you recognize. A is actually Kaposi sarcoma. It's an angioproliferative disease that requires infection from the human herpes 8 virus for its development. It's 300 times more common in people with AIDS compared to the other immunosuppressed population. The other one is actually the pruritic papillary eruption of HIV. It is not an AIDS-defining illness, but it is associated with late-stage HIV infection. The etiology is unknown and is, like I said, typically described in patients with AIDS, and patients typically have a CD4 count less than 250 cells. In these individuals, this particular rash usually appears papular, so it's like a little nodule that rises up. It can be red or it can be hyperpigmented, as you see in this picture, usually very itchy, as the name suggests, and will get better once they're started on antiretroviral therapy. All right, this is just the last question. Which of the following hematological condition is associated with HIV infection? Is it A, non-Hodgkin's lymphoma, or B, isolated thrombocytopenia? Thrombocytopenia refers to platelets, so low platelets. Okay. And okay, so answers actually both. So I'll just explain a little bit. So non-Hodgkin's lymphoma is a AIDS-defining illness. Isolated thrombocytopenia. Thrombocytopenia is actually defined by the American Society of Hematology as an indicator condition for HIV infection. It's actually commonly observed among patients with who are infected with HIV, occurring about 4 to 40%. And indeed, for our hematology colleagues, when they have individuals who were referred to them for low platelets, part of the workup that they do is actually a HIV screen. And we do have a few patients who actually are diagnosed this way. That means they have no other symptoms, just low platelets. And because of that, and the other workup doesn't yield any other causes for the low platelets, then they do a HIV screen and found that that's positive. It can occur independently of all other cytopenia. Means you can just have low platelets, your hemoglobin may actually be normal, and your total wise can actually be normal. Okay, so with this, I've come to the end. If you have any questions, please feel free to put it in the Q&A. I will just move on for now. Give me a moment. Okay, it gives me great pleasure now to actually introduce our next speaker, which is Ms. Xing Ling, Senior Executive for the Action for AIDS, to talk about pre- and post-test counselling. Xing Ling, please.
Thank you, Dr. Chowie. I actually learned quite a lot from the quizzes because I didn't know any of this before. Hi, everyone. Thank you for the opportunity to present today. My name is Jing, and I've been working for AFA for 6 years. And also I'm about to complete my master's degree in counseling at the Singapore University of Social Science. So at AFA, my work is mainly to provide counseling services to individuals accessing our testing service. And also I often train volunteers to become peer counselors as well. So over the years, I have gained some experiences in recommending testing as well as announcing testing results to patients in a way that's more personalized and enabling. Okay, just let me share my slides quickly. Okay, a little bit history about pre and post-test counseling. HIV testing and counseling was first adopted by Action for AIDS in the early 1990s. It was also practiced by some physicians and nurses. We do counseling before and after HIV test because it's an evidence-based practices. A rich body of research has shown that pre and post-test counseling is an effective way to help prevent HIV transmission, to get new patients into care, and also minimize HIV-related morbidity and mortality. So HIV testing and counseling can occur in both clinical and community settings. So the one that Action for AIDS provide is a community-based testing and counseling service. There are some pros and cons when people choose to test at a community-based testing site. The disadvantage is that we do not have doctors and nurses on site to provide medical advice on HIV and STIs. The advantage is that, first of all, our testing is anonymous. So people who have concerns about privacy and leaving records, so they would come to us. Secondly, our service is peer-led. It's for the community and by the community. It sounds very nice, but what exactly does that mean? I'll give you an example. So I am a heterosexual woman who's passionate about sexual health. So if my client is also a heterosexual woman, I can share my experience when I went for STI screening. And let's say if she had unprotected sex, and I would share some strategies on how to negotiate condom use with a partner who doesn't want to use a condom. So the same thing for our peer counselors for the Men Who Have Sex with Men program. The same strategy. I'm a gay man, you're a gay man. Let me share with you some of the benefits of taking PrEP from my own experience. You can easily build trust with client or patient when you can convey the message that, I care about your well-being because I'm part of this too. Whatever you're going through, I've been there and I can relate to your struggles. So besides peer counselors, we also run regular online, offline campaign to promote testing. The newly diagnosed patients can also talk to our peer counselor who's living with HIV. So all these factors really helps to create an accepting and enabling environment for our clients. I would like to share some of the statistics that will give you an idea of the scale of our service. For the past 15 years, AFA's ATS program provides about 6,000 HIV tests per year. This does not include the tests done through our mobile van testing program. Combined with the mobile van testing, we do about 10,000 HIV tests a year. Not surprisingly, fewer people have accessed our service in 2020 and 2021. And there's two main reasons for the drop in numbers. One is, of course, the COVID-related restrictions that has reduced our operating capacity. Secondly, people are having less casual sex due to the closure of bars and clubs and reduced social mingling in general. The overall rate of positive cases recorded in our ATS has been showing a downward trend since 2013. And the national number reported by MOH has also gone down considerably since 2018. This is a strong indication that we're moving in the right direction towards getting to 0 cases. Okay, now let's dive into the topic of pre and post-test counseling. So hopefully by the end of the slides, you'll have a better understanding of what does counseling mean, when is counseling necessary, and how to do effective counseling in the context of HIV testing. First, let's look at the definition of counseling in the context of professional therapies. So based on the definition given by British Association of Counseling and Psychotherapy, to counsel someone means to use the interpersonal relationship to facilitate self-knowledge, emotional acceptance, and to stimulate clients' personal development and adjustment so that the client find themselves in a new position, that of independent and responsible person kept in balance. This is a quite lengthy definition, but I don't know if there's any specific part that stood out to you. So for me, what stood out is the use of the interpersonal relationship. When I'm studying for my counseling courses, I always pay a lot of attention to the factual knowledge, the practical skills, different modalities. But in practice, I realized that holding the correct information is important, but it's equally important to build a good rapport with the client or patient, because without that rapport, we can never really effect change or improve the client outcomes. And I believe that patient can always benefit from a good relationship with a healthcare provider. The emphasis on personal relationship also means that you as a person play a very important role in this process. Whenever you hear the word HIV, or AIDS, notice the thoughts and emotions that automatically arise inside of you. Were there any judgments or association with certain behaviors? If you can confidently say that you see HIV purely as a medical condition without any prejudice, what about same-sex relationship or drug addiction? Again, notice the thoughts and feelings you have when I mention these words. I just want to emphasize that no matter what thoughts and feelings come up, they're okay and they're valid. The purpose is just to be aware of them and understand how they might impact your work with the patient. It's always helpful to do a little bit of self-reflection. I wonder why I have these thoughts and feelings. Is it my family value? Is it my religion? Or perhaps it's my personal experiences? Also, how would you react if the patient tells you that they were a victim of rape? Or if they have cheated on their partners and have engaged in commercial sex? Does any of these things evoke a strong emotional reaction in you? If yes, then you just need to be extra mindful of your personal triggers during your interaction with the patient. It's very helpful to distinguish the difference between informing, educating, and counseling. Usually when we do pre and post-test counseling during HIV tests, we need to do all three. So one, do we need to do inform? When we talk about things like confidentiality or simply giving instructions about booking an appointment, we're just providing information. So that's inform. When we explain what does U equal to U mean, or what are the different ways to take PrEP, we're doing education. And usually you will have a script for these kind of things. So you'll find yourself repeat the same thing to all the patients. Counseling is a little bit different. Counseling is less scriptive. We will provide active support to clients so that they can explore their feelings, they can identify what's their priority issues, and they will be able to make better decisions. When the clients show resistance to treatment, for example, we don't just read out from a journal article explaining the efficacy of ART. We kind of wrote with the patient's resistance. We encourage them to share more, and we validate their concerns. We explore solutions or alternatives, and we find ways to get their hopes up. So this is what counseling looks like. So when do we need to offer counseling services? If we look at this flow chart of HIV management, counseling is maybe required at each phase to ensure that we don't lose any follow-ups. When patients test negative, we assess the risk and encourage them to test regularly. When they test positive, we link them to care and provide the support they need so they remain in care and remain viral suppressed. And most importantly, that they can lead a meaningful life while living with HIV. So we can further break down the post-test counseling based on whether the positive result is confirmed or unconfirmed. And there might be counseling required while the client is started ART. Nowadays, pre-test counseling is more like a brief discussion. Before we adopted the rapid or the point of care test, it used to play a more important role. This is because the counselor or physicians are trying to avoid the case when the client doesn't return for the test result. That's why they try to include a very comprehensive information in the pre-test session. But now most of the settings are using rapid HIV tests so that the client can receive results during the same visit. As a result, a more intensive pre-test counseling is no longer needed. And a lot of times, it actually creates barriers to service delivery. Some regular testers might find pre-test counseling repetitive and time-consuming. Because remember, our goal is to make HIV tests easier, quicker, and more regular. Having said that, there are certain things that the patient needs to know before the test. Confidentiality and anonymity should be discussed from the get-go. We also clarify with clients the reasons for testing and the service available in case of positive result. And finally, we encourage them to ask questions during the pre-test discussion. Another reason why we keep the pre-test session brief or short is because patients tend to be a bit anxious when they have to face the possibility of testing positive. When their mind is preoccupied with worries and fears, whatever you tell them is unlikely to stick. So post-test counseling for negative result can also be seen as a prevention counseling. First, we announce the result and we recommend the need for retesting based on the client's recent exposure and ongoing risk of exposure. Then we take the opportunity to try to reduce the patient's chance of future infection. For example, we will discuss the possibility of taking daily or on-demand PrEP and offer referral to consultation if necessary. Another critical part of post-test counseling is to encourage routine tests. So testing is a behavior. So just like any behavior, there's a trigger, there's a function they serve, and there are factors that helps to maintain it. In my experience, the easiest way to encourage testing behavior is just to use verbal remarks. So to use my experience with the dentist as example, so last time I really don't like flossing, even though every time the dentist asked me to floss. But then one day I started to like flossing, just because this one very nice dentist praised me during while she was cleaning my teeth. She said, "Oh wow, you're doing such a great job flossing. I can tell the difference." So from that point on, and then I start to floss every day. So the same thing for people coming for HIV tests. If the client feels judged, criticized, or dismissed, do you think they will want to come back again? So instead of focusing on where they did wrong, we need to highlight what they have been doing right. So I would say something like, it's great that you're testing every 3 months. You're really on top of your health. So keep up with the good work. Or something like, I'm so glad you have convinced your friend to get tested as well. I wish more people in the community could be like you. And for younger person, someone in their early 20s or below the age of 21, who are testing for the first time, and I always make sure to affirm them. I know it must be scary for you, but you made a great decision to come for the test. Excuse me. So small things like this cost no money, but it goes a long way in normalizing testing behavior. When client tests reactive on a rapid test, the first thing we need to do is we need to explain that the test result is not an HIV diagnosis. Further tests such as the Western blot test is required to confirm the result. But because the Western blot may take up to 5 days, we will also tell the client that they have the option of start ART before Western blot result come out, especially if they have a particularly high risk exposure. But this will be case by case because the doctor needs to evaluate first whether they are suitable to start ART immediately. As you can imagine, receiving confirmed or unconfirmed HIV positive result is often stressful and overwhelming. If you are a patient's first point of contact, meaning that you're the one who announced the reactive result to the patient, just bear in mind that we need to make sure that the patient will come back for treatment, because it's possible that the patient might not come, might not go for treatment and just hide it as long as they can, because they often don't have symptoms. And we know that if treatment is delayed, it creates many problems for the patient themselves, as well as pose risk to public health because they might knowingly or unknowingly transmit to others. In my experience and practice, I always talk about U equals to U, undetectable equals untransmittable during positive result counseling. I'm not sure how often the U equal to U message is delivered in a clinical setting, but in my experience, the message really helps to motivate the patient to seek treatment. I have patients tell me that I can't wait to reach undetectable status. Just tell me what I need to do and I will do it. So if delivered correctly, the U equal to U message can really empower patients to and prompt them to get on ART as soon as possible. Some other issues that may come up in the discussion include the pros and cons of disclosure of the HIV status and additional referral service to support group services. And we might also discuss if the client has other mental health issues such as depression, anxiety, substance use, and how that can interfere with treatment adherence. So just now I mentioned the importance of building a rapport or relationship with the client, but how exactly do we do that, right? So basically, if we want the counseling to be effective, it should be client-centered. What that means is that we want to avoid giving the same message to all patients without considering their personal needs and circumstances. And instead, we try to be responsive to the unique situation of each client. And we start by respecting the client autonomy and preferences. But sometimes you feel like you're trying really hard to engage, but still the patient seems withdrawn or not really willing to listen. So you can check first if the patient prefer to speak with someone of the opposite gender. When it comes to sexual issues, particularly some female clients would feel safer to talk to females, and some men would prefer to speak to a male counselor. We also have transgender clients and clients who are gender non-conforming. So you check with them how they would like to be addressed. And we also try to use inclusive terms such as partners instead of husband or wives, boyfriend or girlfriend. Also find out if the client is in a hurry. Sometimes they have dinner appointments or other arrangements. And if the client has a friend accompanying them and the test result turns positive, check if the client intends to share the result with this friend. If the answer is no, then we don't want to hold them for too long and ask them to come back at another time. Another important skill of counseling is to tend to the client's emotions. A lot of times we jump into the problem-solving mode too fast without paying attention to the client's emotions. For a client whose HIV result turned positive, the client might be shocked, distressed, angry, tearful, or they might not show any visible signs of emotion. And sometimes they might show inappropriate emotions. I have a client who, the moment when I tell him that the result was positive, he starts to tell jokes and start giggling. So just to know that we all have different ways of coping. You could call it a self-defense mechanism, you could call it survival style. So a wide range of emotional response is possible. So instead of saying, oh, I know you must be feeling XYZ, it's always better to ask open questions, such as how are you feeling or how are you holding up? And make sure you give space and time and allow them to settle down a little before you start talking. And the next step is to find out the main concerns, what's the most pressing issues for them at the moment. And we gear the discussion towards that issue to help them address the concerns. And again, for patients who had a positive HIV test result, they might be worried about losing their job.
Sorry, we are a bit short on time. Can I ask you to wrap up in the next 1 minute, please?
Oh, okay, sure. So for a patient who tested positive, so they might be worrying about their job, losing relationships, financial burdens, or simply just wanting to find out how and when they got it. So yeah, I actually only have this one last slide left. There's just a few ways to create an enabling environment for the client who tested positive. One is to highlight the client's strength and resources, which means we don't always have to talk about HIV. We can talk about, you know, what's meaningful to them. We can talk about work, their pets, their families, and we can review certain laws such as the Infectious Diseases Act knowing your rights and knowing the policies and laws always give you more power. And the third is, and I think is very important, is that we give them the option to talk to a peer counselor who's also living with HIV. And my colleague Adrian, he's one of the peer counselor. And so maybe later in the panel discussion, he can share a little bit of his experience being a peer counselor, and what does it look like for him and what does it look like for the client. Okay, that's it. Thank you very much.
Okay, thank you so much, Xingmei. We're now moving on to our panel discussion, Reducing Stigma Around HIV Testing. The moderator of the panel is Associate Professor Sophia Archuleta, who is the Director of the National HIV Programme. The rest of the panel includes Dr. Tan Kok Kwan, who is the Medical Director at Dr. Tan Medical Center. We have Ms. Sherry Sequesha, who is from Project X. We have Mr. Adrian Tyler, who is a Youth Coordinator at Action for AIDS. And we have Ms. Alexander Tay, who is a full-time youth worker at Ugachaga. Sophia, please.
Thank you, Cherry, and good morning, everyone. We're going to use the rest of the time for our panel discussion and Q&A. Thank you for putting some of your questions on the Q&A chat, and for Chen Xiong for answering some of them already. I'm so pleased to be hosting this next segment. We have a panel discussion on reducing stigma around HIV testing and on increasing HIV testing in general. The panelists today are a very diverse group across community-based and non-governmental organizations and general medicine practice that serve our community. I will now ask them to turn on their video, which they have, and take a turn to please introduce yourself and the organization you represent. Adrian, why don't you start us off?
Hi everyone, my name is Adrian. I'm a youth coordinator for Action for AIDS.
Hello everyone, I'm Alex Tay. You can I use he/him pronouns, and I'm a youth worker at Ugachaga. My work involves engaging, empowering, and supporting youth. I'm privileged to do this with Ugachaga, which is Singapore's most established LGBTQ non-profit community-based organization.
Morning, everybody. My name is Kok Kwan. I'm a GP in private practice, and my work in HIV started when I opened my first clinic that was dominated as well as anonymous testing sites. And since then, I've been doing my little bit to try to increase HIV awareness among the primary health community.
Okay, wonderful. And Sherry?
Hi everyone, good morning. My name is Sherry Shakrisha. I'm a transgender sex worker, and I'm with Project X, the only non-governmental organization that advocates and educates for sex workers' rights and their sexual health.
And could I ask, in your day-to-day work and through your organization, how are you involved in increasing HIV testing? Adrian, we'll start with you again.
Sure. So I run the Pink Carpet Y program, in short PCY. So Pink Carpet Y is a resource center for young gay bisexual queer questioning men, 29 years old and below. PCY provides safe space and support to young GBQ men to learn more about sexual health and make new friends. So PCY sessions are conducted twice a month, and free tests are provided to newcomers, students, NSFs, and unemployed. So part of our outreach efforts, we conduct sexual health talks at tertiary institution and provide free tests to the students there. We do hope to work with more schools in future. Besides running the PCY program, I also provide sexual health counseling at our anonymous testing clinic and linkage to care support for newly diagnosed clients.
Thanks for sharing, Adrian. So my work with Ugachaga doesn't necessarily specifically involve raising awareness of HIV and STI testing, but as the main coordinator of our in-house youth program, we have actively been discussing topics that that we feel youth should know about, and one of those has been sexual health. And we actually had a session last year, and last month, and we kind of got a sense of what youth's concerns are when it comes to HIV and STI screening. So hopefully I can share a little bit about that later on in this chat.
That'd be great.
So in my practice as a private GP practice, I try to provide a safe space for people to come and get their HIV test. We also run a Telegram account as well as a website for people to anonymously come and engage us and ask us about their questions and concerns with regards to HIV. And in my personal capacity, I try to reach out to a lot of my GP primary health colleagues to just try to get them on board with achieving our aim of getting rid of HIV in Singapore in the next 10 years.
Right. So as part of projects surveys, what we do is we conduct outreach, and during the outreach, we'll talk about the importance of condom use and sexual health testing. And as a transgender sex worker myself, it given me the privilege to really talk about it openly, and also I would say influence and make sexual health testing, HIV testing normal among the community, and to show that there's nothing for them to be a fear of or to be scared to feel that they'll be discriminated at or anything such. So yes, I'm really glad that I could continue reaching out to all the sex workers that's currently in Singapore.
Thanks everyone for sharing. I think now that the panel can kind of see the range of involvement that our panelists have, we'll dive into some of the questions that participants pre-submitted when they registered for the webinar today. So let's start off with one for, we can stay with Sherry, if that's all right with you, Sherry. One of our participants asks, how can we make our testing services more inclusive to marginalized groups such as sex workers?
I think the one easiest way we can do is to simply be inclusive and also respect all this marginalized community, be it transgender, sex worker, gay trans men, or drug user. The first important step to make it available to them is to respect them, acknowledge them for who they are, and respect their decision, whether they want to be a sex worker, whether they want to transition to be a transgender. Upon doing that, then you already validate that person, who they are. And then it makes it easier for you to approach them asking, would they like to go for HIV testing upon checking on their sexual health history.
Alex, you want to add on to what Sherry said? Same question for gay trans men.
Certainly. Yeah, I think with what Sherry said, I completely agree. You know, the validation is so important when it comes to to ensuring that patients come back for follow-up care. Certainly for many gay trans men that I know, and for myself as well. When we look at key populations such as, you know, trans women and MSM to me as a trans man includes other transgender men, but sometimes programs are whether intentionally or unintentionally exclusionary. So I think when we further define, when organizations and clinics further define, you know, the target populations, and while validating that everyone should be tested if they're sexually active, I think that would be a great first step forward.
Yeah, you mentioned earlier some of the issues that you've observed and initiatives at UGACHAGA. Would you like to bring some of those up now? So maybe some common barriers that you've observed, and best practices.
Sure. Okay. So, well, during one of our sessions, that I do with LGBTQ youth, we call it the Kopi Teh Hangout. So it's like a casual get together monthly, and we talk about different themes. So last month we talked about sexual health, and we did just a short survey, and so it generally based it on knowledge and accessibility for LGBTQ youth in terms of STI and HIV screening. So yeah, I think knowledge-wise, the average rating was on a scale of 7, it was rated at 4.5, so about the middle range. Confidence, the average was a little bit higher at 5.8 out of 7. So that's quite heartening to know that youths are, you know, even though they may have their doubts, they're still very keen on making sure that they are being safe and responsible to themselves and to the partners as well. Some of the themes and the concerns regarding HIV and STI screening were the costs. Some are not aware of maybe some free services that are out there, or possibly these services are also limited in nature. Privacy is another big one. They're not sure where to go and how far this privacy and confidentiality extends to. And also one interesting one was whether there will be needles involved. So, you know, you can see that youth suddenly have limited access to information, or they're not pretty sure where to look at it. There's this kind of like spiral, right, when you're thinking about going for screening, and it's scary. And so this is, certainly something that we need to dispel, these myths about screening. And I think best practices wise, as our speakers earlier have mentioned, quite rightly so, confidentiality and not being judgy when it comes to screening, whether it's at the front desk or in the physician's office. Also, a higher level of anonymity. So I think this is definitely grounds for HIV self-testing, which I think we will be speaking a bit more about later. And certainly youth-friendly and LGBTQ affirming education from physicians themselves. So even if the institution doesn't quite allow for flexibility with things like asking for preferred name and pronouns, the physicians themselves and the counselors can certainly make notes on their end of how to address the patient, how the patient identifies, what kind of words are off limits for them. So I think these in general are some of the good things that doctors can implement in their practice.
Yeah, that's great. Thanks for that, Alex. And I guess, awareness of what type of tests are available can be lacking sometimes as well. So even though getting through the front door is all of the entire journey, right? The entire client experience is important. Even the basic awareness of what type of tests are available could be enough to get somebody through that front door. I'll just remind participants that a lot of this information actually on HIV testing is available actually at all the NCID, National HIV Programme site, but also the websites for the organizations represented right here on the panel and in today's webinar, as well as on Health Hub, both on the app and on the website. There are links for the various HIV testing sites, including some common questions, the rapid tests that are available, types of tests, where to access them, and the anonymous testing. Adrian, how about I ask you how does that, so Alex talked a little bit about challenges for youth. How does that mirror or relate to what you're seeing at AFA in your program?
I think it's pretty similar with what Alex just shared. So it's costing is actually one of it. Fear of having a positive result, misinformation from online materials. I think it's also like fear of judgment if you talk to their friends. Fear of getting testing alone as well.
Yeah. Okay. Great. Kwan, from what you see, you probably see a much broader, I would imagine, cross-section of people coming in to see you across all ages, coming in for the routine medical care, and some of that might include HIV testing. How do you do it? How do you enable, and what would you recommend to fellow GPs or healthcare workers in community practice to encourage HIV testing?
Well, two things I would recommend. First is let us practice what we preach. So as healthcare professionals, when was the last time we did a HIV test? So I do a HIV test regularly. And although I believe I'm not at risk, fingers crossed, that 20 minutes that you're watching the reagent climb up the strip is honestly rather nerve-wracking. And I think that gives us a little bit of what our patients go through, a little bit of experience. So that's my first recommendation. Second is, to my fellow doctors out there, we are really scary people. That is why people suffer from white coat hypertension. So it is doubly stressful when a patient comes in and needs to do something so personal like a HIV test. And honestly, I think we have the first 10 seconds to make them feel completely at ease. Smile, don't fold your hands, make the patient feel really comfortable, make them feel unjudged and safe. And then if we do this to every patient and they tell their friends and colleagues how easy it is, that is how we're going to increase HIV testing rates in Singapore, in my opinion.
Thanks. Why don't we talk a little bit about HIV self-testing now? So clearly that's something with rapid kits available very widely for COVID these days. It's something that testing at home for an infectious disease may not be as new or as uncharted territory as it was before. While our panelists have a chance to think about pros and cons, we're going to ask our audience to do a Zoom poll and tell us if you would use an HIV self-testing kit if it was available at your local Guardian or Watson's tomorrow. Arun, can you help me launch, please? Not sure how many of you have done COVID ART testing yet. As healthcare workers, we've done a lot of them. So let's see what people think about HIV self-testing kits in the privacy of your home. Okay, let's see the results. Okay, 89% yes. It'd be great. I'm actually very curious. We're going to talk about this right now, but I'm actually very curious if participants could write in the chat, if you could, why you said yes, and for those who said no, why you said no. I'd like to really love to hear some of your concerns, and we can use this forum to do so. Thank you. Okay, has anyone on the panel used an HIV self-test? As we know, they're not formally available in Singapore yet, but they have been available through clinical studies. And I think, as our audience may know, they're available online and from overseas. They can be available as finger stick tests or just as an oral swab, which is quite easy to use. So if anyone's comfortable sharing whether you've used one or what you think about the concept of them being available, would it be positive? Would it reduce barriers and increase testing? Or is there something negative about having them be available? Let's start with Sherry. Let's go over to you.
I would say the cons of the HIV self-testing kits would be harmful to the individuals. The reason why I say this is, let's all imagine the situation where these persons get a positive result and he or she is all alone in the room. So if there's no one else around that person, then the person might be feeling doomed, you see, and we might never know what next will happen to that person. So these are the things that we need to consider when, if ever, we're going to provide HIV self-testing kits, because there won't be any support when they got the positive result. So I think people should really think through it, whether we really want to make it a good thing about HIV self-testing kit, because there's no counseling, as one of them was saying earlier on, or support on what to do next if you got a positive result from it.
Okay, thanks. Any other perspective? Kok Kwan, have you had patients using them?
Yes, so personally, I use the oral swab test on myself. I have a lot of patients coming to ask me whether they can purchase the oral swab test to do it themselves. So I do see a demand out there, and I think a HIV self-test really would be a huge game changer locally. I'm totally in support of it. But just like what we learned from the COVID-19 self-test, we need information out there, very, very clear information on what people should do if it's negative or if it's positive, or if it's unsure, if they don't know what the test means. And we need a lot of touch points for our patients to be able to speak to someone with the knowledge to guide them through the implications of their test, whatever the result may be.
Do you think, how important do you think is that information includes some succinct info, for example, about U equals U? Should the person test positive? Would that be encouraging? And or pre-exposure prophylaxis or PrEP? Should the person test negative?
Yeah, absolutely. So when a patient buys this HIV test kit and already has this awareness of HIV to want to test himself, this is a great opportunity for us to then educate the patients on all these other things that you really rightly mentioned, like PrEP, like U equals to U. So yeah, it's a great gateway for us to educate patients on these things.
Yeah, I like that concept of a gateway, and in a sense, right? The person is already there and interested, as you said. What can, I guess to help our attendees we've made some comments about organizational level involvement. What could participants who may be here today from the lay public, what could they be doing? What is the right approach to either get themselves tested or to encourage a loved one to get tested? Adrian, what do you think?
I think it's mostly providing the support by, like I feel that it's important that even up till now, HIV is still a taboo topic and it's not commonly talked about in family settings, social settings. And I feel that, if you don't talk about it and, if let's say one of your friends might need some knowledge and, to go for testing, it's going to be hard for them. So I just feel that, for anyone who attended the talk today would, talk more about HIV, and so that, if you have any friends who might, want to get tested, at least they know where to turn to and they want to get information about it. Yeah.
Alex, anything you'd like to add?
Sorry, Sophia, I think the connection was a bit choppy on my end. Do you mind repeating
choppy.
the question?
Sure. Just some last minute tips or messages. What would you like our participants who maybe from the lay public want to take away from this? How might they encourage a friend or loved one to go for testing?
Well, I think certainly having conversations about it in general, like as a friend, not necessarily asking them directly, have you gone for an STI test or an HIV test? But just chatting about it, if you saw something on the news about self-testing kits or where testing is going in general, bring it up over dinner, just create that safe environment so that if or when they decide to get tested, they'll feel safe letting you know that, hey, by the way, I went, or if you got tested yourself, you could also just share casually like, oh, I just happened to go for like my test today, came back negative, whatever. Yeah, so definitely normalizing it, incorporating it into any kind of conversation would be good.
Okay. Sherry, any last message from you for our audience?
Right. So I would like to say, I believe everyone in the panel and also the presenter has done well and enough to provide easy access, safe and inclusive HIV testing. So what's left to do for me is for sex workers to take charge of their sexual health and get tested. What I do during physical outreach is often to check on them and also to talk about their sexual history and exposure. This allows me or even helps them to be more aware of the window period and when they should get tested so as to get affirmative result. So this to say, it's not just about making people going to get tested, but also to educate people on the window period so they know when they should get tested and not just, oh, today I have sex and tomorrow I'm going to get tested, because it won't help at all, you see. So it's really important to talk about window period, not just about HIV testing.
Thank you so much for that. And thank you to all our panelists for that. Incredible to share both your personal experiences and those of the good work in the organizations that you represent. As we heard from Chen Xiong and from Cherry and from Ting earlier, there are it's still a very important area. Singapore hasn't met the first 90 yet. We'd like to meet it and exceed it. Everyone should know their status. There is testing available, lots of options on the menu. There's treatment available and there's prevention available. Hopefully soon we'll have self-testing as part of the menu as well to decrease barriers as much as possible. And for all of us in the community, as well as healthcare workers, to do our part. We will close the panel now in order to hear from Chen Xiong. Dr. Wong is going to take us through some closing remarks and some housekeeping as we wrap up this morning. Thank you so much, everyone.
Thank you.
Thank you to the panel once again for the lively discussion. Before we move on, I just want to extend an apology to Alex. His address should be Mr. Alexander. I will now also invite Chen Xiong back on to deliver his closing remark. Chen Xiong, please.
Thank you so much, Xiaoyi. Thanks so much to Sophia and all the panelists, to Alex, to Adrian, to Sherry, to Kok Kwan, and to all of you for submitting your questions, both in advance via email and also during the discussion itself. I think it really helped shape the complexion of the discussion. I know that there were some questions we didn't manage to get to, and I think what we will try to do is look at those questions and find some way of getting some responses to you guys, perhaps over email, but we'll try to work something out. So once again, I just want to thank everyone for taking the time on a Saturday morning to join us in this discussion. And I really want to echo maybe the last thing that Alex said, which was, having conversations and safe spaces amongst friends, family, and loved ones. One of the reasons why we wanted to have this as a community engagement forum was because, hopefully all of you can act as amplifiers, right? As loudspeakers, as Wi-Fi meshes. I can't think of any more metaphors, but to amplify the message that we're talking about HIV, understanding what it is, doing away with some of the stigma and getting people aware of HIV testing and hopefully moving that needle for that first 90 that I talked about. Now, before I close this morning's Community Engagement Forum, I would like to, on behalf of the National HIV Programme, my colleagues and friends, extend a very warm invitation to you to attend the second Singapore HIV Congress, which will be held on the 27th of November and the 4th of December, respectively. It's 2 sessions, 2 half-day sessions in the morning. This is, of course, our homegrown National HIV Programme-owned HIV Scientific Conference, and we have a really exciting lineup of speakers this year, both regional as well as national experts, talking about a wide range of topics from HIV self-testing all the way to HIV cure and the latest in our HIV treatment and prevention guidelines. So, do take the chance to come and join us in this particular Congress this year. If not, then thank you once again for your participation, for attending, and most of all, thank you in advance for spreading the message about HIV testing. We hope to see you really soon. Please, before you go, do scan this QR code so that we can bring you to our feedback form, and also for you to get your CPE points. All feedback that you give us is very, very useful because it helps us craft an even better program for the next forum. Thanks so much.
Thank you again, Chen Xiong. Ladies and gentlemen, we've come to the end of the program. As Chen Xiong mentioned, before you sign off, please help us fill out the feedback form on program today by scanning the QR code on the screen. You can also scan the code for CPE points. We hope you had a fruitful morning with us. Thank you so much for spending your time with us, and have a pleasant weekend ahead.